So good afternoon, team. Thanks for joining on today's session. So this is session number 5 that will be talking about emotional and psychological support in patients with CKD. So I'd like to welcome all of you for participating in today's session that will be presented by Erin.
All right, well, it's great to see you all again. I know we were on a break last week because of the public holiday here in Kenya for Easter, but it was, it's nice to be back and to see you. Hi to Gladys, Dr. Mazar, Raffaeli, good to see you, Francis, Sifa, and Lillian. I know quite a few of you I've interacted with over WhatsApp over the last few weeks, and I'm continuing with some of the field visits. So please, as Dr. Azael said, don't hesitate to unmute during these training sessions. This is just one aspect of our supportive care program. Obviously, I'm here to support the work, and we're hoping with you as champions and others in the team, we can continue to give our patients good holistic care. So today we're actually going to be talking about emotional and psychological support. We know that many of our patients need this, and it's not easy to do. It's not easy to support patients with chronic illness, but today we're going to talk about just a better understanding of what can we do, how can we engage with our patients, and how can we continue to, again, give that holistic care and support to our patients with chronic kidney disease. So again, this is our Kidney Supportive Care Program. It's a new program at AHN. We're rolling it out through you as champions, as well as in our general IECHO training programs. And it's 12 sessions. So we're on number 5, as Dr. Azael had mentioned. We're coming up to halfway, which is great. And we're going to continue with different topics. We're hoping in the next week or so we can start these discussions as well. So by the end of the session today, we're hoping that you'll be able to address emotional challenges as well as psychological distress in patients and families with an approach called trauma-informed care. So it might be a new concept to you, but that's okay. We're going to talk about it together, as well as apply some counseling techniques and coping strategies for your patients, and identify the signs of depression and anxiety so that we can provide the appropriate support. And sometimes that does mean referring for more specialized treatment that we can't give as generalists. So by the end of the session, we're hoping that you will become more competent in providing the emotional and psychological support to patients and their families that are dealing with kidney disease and kidney failure. So what is trauma-informed care? What does that really mean? So this is actually an approach in the human service field. So when we think of this field, it could be in healthcare, it could be the service industry, obviously humanitarian situations, police, these kinds of things, where what we need to all assume whenever we engage with humans, obviously that's very basic, but what we need to know is that individuals have a history, could potentially have a history of trauma. We all know that there are things that happen in our lives that may affect how we interact with other people. And what we want you to begin to understand after the session today is that actually a lot of our patients have experienced some sort of trauma. Trauma could be related to their illness, or it may not be. But this does affect how they react to us as healthcare workers. So an individual trauma results from an event or a series of events that's experienced by an individual. It could be physical or even emotional. It can be harmful or potentially life-threatening. That has an effect on someone's mental, physical, social, and even their spiritual well-being. So when we think of this, it could be something, and most likely our patients that are in their 40s, 50s, and 60s, they've lived a long time. They've experienced traumatic things in their life. Some of it could be related to their kidney disease. Some of it could be related to other aspects of their life. But we want to begin, and if you're already doing this, that's great, but we want to begin to provide care to our patients through a trauma-informed approach. So again, we know that there's some challenges as we do kidney supportive care. We need to, we understand and acknowledge that there's a need to understand our patients' life experiences in order for us to deliver effective care. So this goes beyond their weekly dialysis sessions. For us to be holistic clinicians and nurses and nutritionists, medical officers, we do need to begin to think bigger than our patient's blood pressure and their blood work and their dialysate that they're getting. We need to think beyond that to be able to give them this care. And this approach has the potential to improve their engagement, potential to improve their treatment adherence, and even their health outcomes. But we know that most traditional psychological therapies are often needing to be accessed by healthcare providers, mental health care providers. Treatments often take time and could be anywhere between 8 to 16 weeks. And sometimes the therapy sessions are really long. So in reality, the challenges seem quite great. For our patients, and for us to be able to provide this type of care, an illness can actually serve as the primary traumatic event. So a patient being diagnosed with chronic kidney disease is actually traumatic. It impacts most aspects of their life. And although we may altogether not want to see them as a patient, it is a situation that has happened that has changed their outlook on their physical, their emotional, their psychological well-being, for sure. Patients also can have experienced past trauma, for example, conflict. They can have difficult family dynamics. They can be displaced. They can have a loss of their job, even close family members who have died, an accident. And sometimes when patients have to return to the hospital or they have to go through treatment, it can actually reactivate a situation in which a patient's experienced something that was really difficult, and they start to relate that to what's currently going on. This is really important for us, and you might not have thought about this before, but it is important as we think about supportive care and holistic care of our patients. So where do we start? It can be really overwhelming to know how to recognize trauma in our patients, to acknowledge it, and then to know what to do with it. So first, we do want to allow ourselves as healthcare workers to recognize the situation as traumatic. So patients could have distressing memories. They could have, some patients have intrusive thoughts. Not all of our patients, but some do. Some patients avoid talking about it or thinking about it. Maybe they don't share how they're emotionally doing with us because it's just too difficult. We as clinicians need to sit and listen. We can provide empathy by expressing it. We can say, I can't imagine how this must be. An anniversary of their spouse death. And it's a really difficult day, and that's the same day they have to come in for their routine dialysis. We notice something a little bit different in our patients, and we can say, I can't imagine how difficult it must be for you to be a widow, for you to be without your spouse. I can't imagine how scary it is for you to have to go through this dialysis alone. Being empathetic can allow us to engage with our patients and to do something that we call, and I'll speak about it later, is to sit with suffering. To engage and sit with difficult situations, even when we may not have necessarily an answer to solve the problem. Living with a serious illness, such as kidney failure or chronic kidney disease, many of our patients also have other issues and other illnesses, can affect patients' abilities to cope. Some patients have a lot of difficulty making medical decisions. Their function in their normal ability before their diagnosis could be quite different after being diagnosed with kidney disease or kidney failure, Managing medications can also be really difficult, and also addressing pain and other distressing symptoms can make it really challenging for our patients to manage, and it affects them. So we're going to talk about a stepwise psychosocial approach that was developed by David Feldman in 2017. And this helps us to support our patients who may have experienced a traumatic situation, and it allows us to do it in a trauma-informed way. So we'll go through the next 3 steps. So, the stage 1 is at the top there in the blue is the step. So Step 1 is to palliate immediate discomfort and provide social support. So if a patient has a physical or an emotional discomfort that we're able to identify and address, we need to do that. So if they're in pain or they're quite emotional and they're not able to eat their food because they're so emotional, we need to address the immediate situation and then provide support. So maybe their caregiver is with them, but just in the waiting room, we could potentially invite them back in, knowing that it's a really difficult day for the patient. We do this by developing trust with a trusting relationship with the patient through active listening. Again, we express empathy. We have to ensure that our patients know that their concerns are also what concern us. And we know, of course, in our clinics, we're really strapped for time. We don't have a lot of time to support our patients, but it is important that we try to think of ways to do this, to give that holistic care. And then again, if there's in the physical environment that we need to consider, we need to do that. For example, if there's a patient that has had issues in the past, potentially getting their dialysis in a certain area, then we can acknowledge that, and then we can come up with a way to change that environment. The next step or stage is to provide education and help them enhance their coping skills. So we want to educate our patients on living with a serious illness, on their medications, and what their plan of care is. And this is done often, of course, at the bedside, and this is done by all the members of our team. It's not just done by the nurses. It's not just done by the clinical officers. We regularly educate our patients, and this actually helps our patients cope. If our patient is having an emotional time and they're actually crying or they're hyperventilating, we can help and teach them different techniques, including relaxation or breathing techniques that can really help. So deep breathing, breathing and counting to 5, holding your breath, and then breathing out, counting to 5 can really reduce our patient's heart rate and hopefully get them to a point where we can talk to them and support them, and they can share a little bit more about what they're going through. So in the third stage, we want to treat specific trauma or ensure that a mental health disorder that a patient may be experiencing is addressed. So especially, on the slide here, it says we can only go forward to stage 3 if we've done what we needed to do in the earlier stages. So if we haven't been able to alleviate suffering or symptoms that are causing the situation, and if a patient's prognosis or energy allows us to have a longer-term strategy in place. As we mentioned earlier, mental health support and referrals obviously are very important, but they do take quite a bit of time. So we need to be very concerted in what we do and the referrals that we make. And again, if we know a patient has struggled with depression in the past, or they have a traumatic situation, or potentially they're even a refugee who's been in a conflict setting and could have experienced trauma that was not properly treated, and it seems to be affecting the way that they engage with us at the dialysis clinic, it's very important that we acknowledge that and come up with a plan of how to support them. So when we think again about physical situations, physical pain, physical symptoms, we want to ensure that the pain and symptoms are controlled, that psychological, social, as well as spiritual support are all included in the supportive palliative care that we provide. And this, again, is a reminder that we do this for our patients and their families. If we were to think about a psychosocial assessment, when we do an intake or when we engage with a patient, we need to make sure that we're not just asking some basic questions on the assessment form, like how much do they smoke, or do they have a substance use disorder. We also need to consider a patient's environment. What's their perspective on their current living situation? All of this goes into understanding the psychosocial environment of a patient. And it's not just the location of where they live. and the county that they live in. We need to better understand our patients compared to just those minimal things. That's really what we know. So in 2017, in the Journal of Pain and Symptom Management, they identified that there's actually not a lot of information and a lot of support in terms of understanding what does this psychosocial assessment look like. What it showed in the research is that most assessments didn't include items such as their physical and functional status, their preference of treatment, their understanding or their awareness of their diagnosis, their prognosis or their disease progression, their communication, or even their health literacy. And it didn't include cultural values. And this was an assessment that was done over 105 hospice organizations. I assume this was probably done in the US. And that just goes to show you, even in situations where palliative and hospice care is given, not a lot of people are thinking about these other aspects of a patient's life. So what can we do? What are your thoughts? And I'd love to get some discussion on the chat. What are some things we could do to better understand our patients? I recently spent some time with Lillian and her team at Metropolitan, and it was quite interesting to see how their team knew their patients really, really well. So there's probably already some things that we are doing that helps us better understand our patient's emotional and psychosocial situation. We probably actually have a lot more information in our heads and in our heart about our patients than actually is documented in their chart. But I'm curious what your thoughts are. Yeah, sorry, I was coughing a bit. I just took some water, so I'm okay. Yeah, true. Dr. Mazar, we can have social circles. Maybe there's some sort of support that could be created while our patients are waiting for dialysis. Chances are there's probably some common patients that come on the same time at the same day of the week. So they already are kind of forming some sort of community. They have things in common, such as coming to dialysis. What can we do to better understand our patients in this way? I know in Kenya, we often ask our patients how they're doing when they come in, and it's a general greeting. What if our patients say they're not doing good? Do we have a way of engaging with someone when they're having a bad day? Or do they not tell us that they're having a bad day? I know, Lillian, we had a patient that was going more progressively blind in the last several months or years, I guess. And it was quite interesting to see her mood and to engage with her. And with her, she obviously had things in place that she was able to do to make sure her quality of life remained positive. Sometimes when the people closest to patients assume the patient is doing okay, because in the past they've been doing okay. But I think one of the things I want to challenge you with today is to think about and acknowledge that there may be times when our patients are not doing okay, when they're frustrated with dialysis, when they're not feeling well. And we need to have some good ways of acknowledging it. It isn't easy to acknowledge that someone is not doing well. Yeah, really good. Gladys, I like that. Nonverbal communication. If you can see a patient maybe is avoiding eye contact or kind of looking down at the bed sheets or the blanket that they have over them, there may be something that they're not telling us. Yeah, and Dr. Mazar, they usually don't tell us. And I think that's probably something that's quite common amongst kidney failure patients. They're quite used to coming to dialysis, doing the same routine every week, that unless something really big has happened, they may not say it. And I think in general, we are interested in supporting our patients. I want you to consider a few other concepts today, and then we'll stop for our time of discussion. So there was a book that was written by Harvey Max related to final words for final days. And it is a concept of therapy or dignity therapy, in which we asked a person a question. And it's not a question. So oftentimes we ask very medical questions or very clinical questions to our patients, but this is a simple open-ended question. And the question is, what do I need as a clinician or as the medical provider to know about you as a person to give you the best care possible? So not actually a very common question we ever really ask, but it's interesting. So what do I need to know as your nurse today about you as a person to give you the best care possible that I can give you today? So maybe that day was the patient's birthday. Maybe you knew that because their chart said that. Maybe it was something that you didn't know about the patient, and it would actually help you give the best care possible to the patient that day. Of course, you might not ask this question every single time. Maybe this is a type of question you would ask once a month or every few months during one of our supportive care appointments. But you could also say, what brings you joy? It helps us understand different aspects about our patients and helps us give them better care. Maybe we know that the patient really loves reading or really loves watching movies, and we can go out of our way to make sure there's a book at the clinic. Or when you're walking by the market and you see a book on sale, maybe you would consider buying it because you knew that that person really loved, or maybe they were an author. We sometimes don't think about our patients in this way. And again, I told you I was going to give you guys some challenges today. I want you to begin thinking about your patients in this way. Yeah, Sifa, I see that you've written in, we can do a bedside chatting with them, 4 hours with them. We can, yeah, definitely, we're with them for long periods of time for sure. This will help them see that we have time to listen. Yeah, I think it, as we begin to think differently about the type of care that we give our patients, they will begin to respond. As we begin to continue to acknowledge them as humans rather than just patients or people getting dialysis, it really will help us give more holistic care. So the other thing that we're going to talk about today is that total suffering. We've talked about it previously, but that suffering can occur in the physical situation. So usually we do use treatments like pain medication to treat this or other symptom-related medication. We know that the physical pain that patients experience interferes with other aspects of their life too. Patients can feel spiritual suffering. So they might be worried about what will happen after they die. They might have guilt about something that's happened in their life. Patients also experience suffering related to their emotions. They can have adjustment disorders, anxiety, or depression. They can also feel really frustrated with the current situation that they're in. And then, of course, our patients also have that social suffering. So they can be distressed related to family members or their caregiver. They might experience suffering related to a loss in their job or even a role in their family. Maybe they used to be always involved in preparing food and supporting their family, and now they're no longer able to do that because they're quite tired and they're often having to come for treatment. These are all things that can cause suffering in our patients. And there's an interesting article that was written in 2016 that talked about sitting with suffering. It's not something that we all are very good at, and many of us are not gifted at this. We often want to avoid suffering. We want to make the suffering go away. But we know that patients that have chronic illness, such as kidney failure, they need us to sit with them while they're suffering. Of course, there are many things, and that's a huge component of palliative care, that we do all that we can to reduce the amount of suffering that our patients experience. But there is a point that we are not going to be able to 100% minimize every single aspect of suffering that a patient has. And these are the moments when we need to engage with them and sit with them in their suffering, not allow them to be alone in those moments. Oftentimes this does come towards the end of a patient's life. And I know at our clinics, we obviously don't provide end-of-life care, we provide dialysis. But it's this paradox in which we as professionals want to relieve every type of suffering we can, yet we know that there's going to be there is a moment to be with our patients. When there's unrelievable suffering, we may feel a sense of failure, but actually need to find ways to acknowledge and bear and what happens in their families and journey alongside them during this really difficult time. It allows us to show a lot of respect and dignity, knowing that we have used this in terms of management and we begin to rethink about our role as clinicians. We do our psychosocial assessment of our patients. There are certain things we can ask our patients. So these are things that you may want to jot down if you have a paper or a pen to begin to understand more about our patients. So we can ask them what helps you cope. What are things that have helped in the past when you've been really anxious or worried about something and it's really helped? We can also ask, what are you hoping for? Maybe there's a situation in their family, maybe there's an event coming up. This can also help us understand. Maybe they're anxious about how they're going to afford a wedding of their granddaughter, or their son is getting married. These are things that can help us better understand our patients holistically. How are your spirits, or how is your mood? What gives you joy? Are there things that bring you joy? And again, what helps you cope? We know that the psychological distress our patients experience, they're related to a variety of things. So you know this as a frontline provider, they're often related to the disease, so kidney failure. It can be related also to lack of information about their illness. They maybe not fully understand, maybe they're feeling shy about asking more questions. Psychological distress can also be from those uncontrolled symptoms, or maybe they're worried about a specific. That can cause psychological distress. Also poor communication, again, that loss of role. And then if there's a specific stigma associated with it can cause distress in our patients. So what are some specific things that we can do if we are trying to give more holistic psychological support to our patients? We can do this through communication. So it needs to be non-judgmental, and this is done through providing emotional. We can validate their emotions by saying it's common to feel like this, not isolating them and saying that, oh, you're the only person that has ever felt like this. No, I want to say it. It's really common for patients who have kidney failure to feel really tired and not able to do the activities they want to do. It's common to feel sad. You could also say, I can't imagine how difficult this must be for you. Get you to read the last few there, and then if we can go back to the chat. Again, after we've talked a little bit more about this, what are some things that you've done to provide psychological support? I know it's not easy for us as clinicians to offer time. So just as if you have kids, or if you're married and have children and you hear your child crying, you just want them to stop crying. So you can move on to the thing that you're really hoping to do. But actually we can grow as humans, and we can help our patients grow as we find small ways to acknowledge what they're feeling. And yes, of course, there are going to be patients that are clinically depressed that need to see a psychiatrist or a psychologist. They're not able to manage, and they have a chemical imbalance in their brain. It may not be the majority of our patients, but through this program, through the supportive care program, we're wanting to find better ways for us all to provide generalized psychological support to our patients. It could be, I know that during special events at the clinics, we sometimes change the environment, we decorate, we celebrate with patients. These are all ways to continue to support their psychological well-being. Maybe some patients have special music that they like to play, or specific TV shows they like to watch. Again, these can all be different ways that we can support the patients. And when we think about psychological, we also think about a patient's social situation. So obviously, usually this means their family. The unit of care is the patient and the family. So we know that their illnesses can often impact friends and families. It impacts their finances, their ability to make income, the education, and even caregiving. So patients, and specifically families, need information. So they need to know what to expect for the future, especially for our patients that are on dialysis. They need to understand if it's a chronic thing, if the patient is going to be on dialysis long term. Patients also and families need emotional support. So to their caregiving, it could be to the grief that they're experiencing as their loved one changes, be practical support. I'll go through the next ones fairly quickly. There's just a few more for today. So we'll just finish with talking about depression and anxiety. And then I'm curious to hear more about the patients and some of the psychosocial issues that you are supporting your patients. So specifically related to depression, depression is a persistent low mood or loss of interest in everyday activities. We often treat these with SRIs. Anxiety is an intense, excessive, and persistent worry and fear about everyday situations. Patients can have a fast heart rate, their breathing can be increased, and they can feel really tired. We often recommend relaxation for this, and if a patient is able to start antidepressants, it also can help. But of course, they do take time to start working. I can share this on our WhatsApp group, but this is a really helpful image to better understand the signs and symptoms of depression. So again, that feeling of sadness, loss of interest in activities, trouble sleeping or oversleeping, changes in their appetite. I think I mentioned this one earlier, but these are different random controls that patients with kidney disease have tried. So the first kind of column there is the medication. So SSRIs for our patients. Some of it showed effectiveness for our patients taking sertraline. Cognitive behavioral therapy, which is sessions that are led by a psychologist, did show a reduction. So on this last slide here for today, when we think about anxiety, in the first column there, it shows anxiety. So this is an emotion that all of us have experienced at some time in our life. Not all of us will have experienced an anxiety disorder. So a normal reaction to stress, having difficulty finding a job, that can all cause anxiety in somebody. You also might feel nervous or you sweat before a big performance or a test. It starts and then also stops. Relaxing and breathing can help you make a person feel better. And this experience of anxiety or this emotion, it lessens or reduces when the situation is over. Patients who have an anxiety disorder have a constant, unsubstantiated worry that causes significant distress. So it's disproportionate to, it can become irrational, and sometimes it feels impossible to manage or control. So you can see some of the symptoms that are experienced on the right-hand side. So I think it's quite important for us to know and begin to understand. Of course, this is not our specialty. We're specialized in dialysis and in nephrology and kidney care for patients. And obviously we're getting more knowledgeable about supportive care, but it is important that you understand the differences between depression and anxiety and having anxiety disorders. And then speak to the clinical officer or even the medical officer on our team to better understand how to support our patients with these situations. So in general, today, we talked about addressing emotional challenges of our patients through a trauma-informed approach. We talked about different coping strategies and techniques, and then also identified the signs of depression and anxiety. There is some other good resources in the palliative care toolkit, and of course, the online curriculum for conservative kidney management. If you haven't had it, you can check out that website. I can add that one to the chat as well. Just some resources, and we'll just take time for questions now as we end.
Thank you for a nice presentation. I would like to welcome the team for any question, or if you'd like to get any clarification.
Yes, it is a presentations. I get a lot of points. As we are nurses, you've done a lot of things pertaining to the patients, reassuring them. I think most of this we practice, but we don't know. This is palliative care ward, but at the ward, talk with the patient regard the situation, coping mechanism. Sometimes you get a situation with the patient come very frustrated. You sit with them. What is this? What's your things suffering from you all together and get the conclusions. Maybe you can rent by hospitals. You can the bus fare. The issue is fair. So you can sit with the patient. Every day you use maybe 10K export. How if you can rent a house, can solve it? Yes, I think this you can solve. So this is things we continue work with that. So my side, I get a lot of things to know. Now I know that is palliative. Thank you.
Yeah, thank you very much, Francis. I think Erin mentioned that most of these things we might have been doing. It's not like they are new stuffs. These are the things that we have been doing in one or another way when you are seeing this patient. So how we can make them coordinated and how we can make them standard. I think that's why this session is about.
Yeah, for sure, Francis. To have those kind of, sometimes we just as small things here and there. It's psychosocial support for our patients. So sometimes in our documentation, there's not a lot of easy places to write that in, but I think it can be really helpful for the clinicians and others to know that we've had a discussion with someone. We've given some recommendations, and this is how things are going. I think it shows good holistic care. And these kinds of things are actually really important to our patients.
Thank you, Erin. Do you have any closing remarks, Erin?
To talk about topics that, again, might be things that you've done, you've tried, and just really kind of understanding a little bit of the reason why we do this. Next week, we'll be talking about spiritual care for our patients, and it may be something that you normally do, but it's good for us to engage and discuss it together so that it does become part of care of all of our staff, and it becomes the type of care that our patients expect. I'm really excited to continue, and please reach out if you have questions during the week.
Thank you very much, Erin, and I'm sorry for that.